Good afternoon. My name is Dr. Jill Einstein, and I'm the Senior Director of Physician Engagement for MAVEN Project. Thank you all for joining us today and our friends at Clinica Sierra Vista in Central Valley of California for hosting today's session, Approach to Patients with Joint Pain with Dr. Kathy Upchurch. Dr. Upchurch retired from the UMass Medical Center, where she was the clinical chief of rheumatology for over 10 years. She is a professor of medicine at the University of Massachusetts Medical School. Dr. Upchurch's abiding passions throughout her career have been the care of patients with all rheumatic diseases and medical education. She has been a leader in the Massachusetts Medical Society and the American College of Rheumatology and was selected in 2017 to be an ACR Master. In 2015, the New England chapter of the Arthritis Foundation honored her with the Marion Ropes Award given to one area rheumatologist annually for excellence in arthritis care. Dr. Upchurch, it's a pleasure to have you with us today, and I'll turn it over to you.
Thanks, Jill. Hello, everybody. First, I want to just run through a few disclosures. That is, I have none. Secondly, I wanted to point out the accreditation details that Dr. Einstein said to you already, and I want to encourage you to fill out the surveys because it's worth it to get CME, particularly for those who need to apply for their licenses every few years. Now, I'm talking to you today about a topic that's of great interest to me because I think that rheumatology arguably is one of the disciplines that depends upon clinical medicine as much as any discipline that we are exposed to. And by clinical medicine, I mean the art of listening to a patient, examining a patient, and then certainly using diagnostic studies. But what we're going to be talking about today, and I'll be emphasizing over and over throughout this talk, is that I would guess about 80% of rheumatologic diagnoses can be highly suspected and most of the time correct just by listening to the patient without requiring any specific laboratory studies or even sophisticated diagnostic techniques. So even though we have those certainly at our disposal, today's talk really is going to help you focus on your patient when he or she walks in the exam room and has a complaint about joint pain. It's going to hopefully provide you with some type of structured way of assessing that patient and of beginning to think in a logical way about the differential diagnosis of the person that you're seeing. So what I hope to do today is to help you distinguish between different types of musculoskeletal pain, to review the diagnostic approach to the most common causes of different types of joint pain. And then also, I really would like throughout the talk to help you understand when it's appropriate to initiate a rheumatologic referral. And that would include when you call a rheumatologist and say, I have a patient that I want you to see tomorrow, when you send a patient to the emergency room, hoping that they can see a rheumatologist tonight, and also when you can simply ask for a rheumatologic consultation as an outpatient at the earliest convenience, which unfortunately in this day and time is in the order of months. So I'd say there are many more rheumatologic referrals that are more appropriate earlier rather than later. And just one thing to emphasize in this, you are the patient's advocate. So if you do decide after you've talked to the patient that you want the patient to be seen by a rheumatologist, you're going to be most successful not asking your nurse to call another nurse in another office or another medical center, but picking up the phone yourself and doing some of that groundwork because a doctor-to-doctor referral is the most effective way of getting an appointment in a very, very early fashion. I want to start with a case. This is a patient that unfortunately I saw all too often. 45-year-old male who came in and he had a 2-month history of bilateral hand pain. He had 4+ morning stiffness, which lasted for 2 hours every morning. He had a pretty profound list of constitutional symptoms, including on questioning a low-grade temperature, no higher than 101, but generally almost every day at least 100, and severe fatigue. On questioning, he did acknowledge that he'd had a history of recent intravenous drug abuse. He also complained of a lower extremity erythematous mottly rash. And this was confirmed on physical exam, and the rest of the physical exam was unremarkable, with the exception of soft tissue swelling of the PIP joints, which are the middle knuckles, the proximal interphalangeals, the MP joints, which are the first row of knuckles, the most proximal to the body. Metacarpophalangeal is what that stands for. But despite the PIP swelling, the MP joint swelling, there was no deformity. He did have some pain when he attempted to make a fist, but he was able to do so. So without hollering out the potential diagnosis that you think he's got, I'd like for you to file it in your ahead, and we'll come back to the correct diagnosis at the end of this lecture. But this patient most likely has rheumatoid arthritis, lupus, hepatitis B, or hepatitis C. Now, what is arthritis after all? It is any of more than 100 rheumatic diseases and conditions that affect joints, also affecting possibly the tissues which surround the joints and other connective tissue diseases. And this comes from the CDC definition about what actually arthritis is. What causes arthritis? It's any one of 100 conditions or more that affect the joint structures as we just defined. And these include both systemic and localized inflammatory and non-inflammatory diseases or disorders. Now, you may have already realized, given the very, very nonspecific, broad nature of the language expressed in these last two slides, that this is a huge field, and there's a huge number of options that are possible with virtually any patient that comes in with a complaint of joint pain. Now, before I turn to the meat of this lecture, I'd like to just go over the structure of a joint. Now, this is schematic. It could be a knee, it could be an MP joint, it could be the elbow, it could be any joint. But basically, the periosteum is the lining of the tissue, a lining of the bone. And this is notable because it's very, very sensitive to pain. And so if you have a hematoma in the periosteum, it's extraordinarily painful and tender. The joint capsule is the fibrous attachment of the joint tissue, excuse me, let's get it back, that surrounds the joint. This is this tissue that I'm pointing out here. And there are little tiny dots that you can see here. And these dots reflect what's known as the synovium. And the synovium is a very fine single-celled layer, which basically enriches the joint by producing synovial fluid, a very small amount of synovial fluid in most cases. Now, all of you know that the tendon is the end of muscle. And so the muscle here, the end of the muscle, and the tendon actually inserts into the joint capsule. And then we have a subchondral bone plate here. And what you all are aware of is called articular cartilage. To confuse matters in terms of what leads to joint pain is the fact that derangements in any of these areas can cause profound joint pain and loss of function. So you have to be a pretty good diagnostician to figure out where things go wrong. Now, the first thing that I always think of when I'm seeing a patient is what could be the pain driver. So we've already seen that it could be extra articular outside of the joint space itself. It could be periarticular, tendons, for example, or it could involve the articular space. And if it's extra articular, what are the possible sources? Many. The thing that is quite concerning with regard to extra articular source of pain is pain that's referred from another location, and that would include neurogenic pain. An example of that might be sciatica or cardiac pain. And wouldn't be the first time or the last time a patient would come in to me thinking that their shoulder had been bothering them. And in fact, what they have is a recurrent angina, which is referred to the shoulder and then sometimes often down the left arm. So that has to be included in what is considered a possible extra-articular source. We talked briefly about the periarticular structures and then, of course, the articular structures. Now, there are a lot of things that mimic joint pain. So the patient thinks it's joint pain, but it's not really. So I'm going to amplify what I just said about the structures, the extra-articular structures. So myotendinous pain is tenderness distant from the joint structure, but it corresponds to the muscle and then the part of the muscle that turns into the tendon that attaches to the bone around the joint. Um, Neurogenic pain usually has no tenderness at the site of perceived pain. Doctor, my hand hurts. But provocative maneuvers that result in nerve stretch may lead to pain. And those would include things like a straight leg raising sign or also Tinel's sign, which taps on the wrist and leads to pain at the carpal tunnel. So the distribution of neurogenic pain, and this is a clue when you're talking to the patient, is often related to a dermatome, myotome, or myotome of a specific nerve root or peripheral nerve. So when you talk to a patient who has pain in the left leg, for example, you'd have to be sure to ask if they've had any back pain, if they've had any numbness, if they've had any tingling, if they've had any weakness, and then focus your exam in that regard if the answer is in the affirmative. Now, other red flag type mimics of joint pain include, as I mentioned, cardiac with left upper extremity often, but sometimes right upper extremity radiation, vascular pain, particularly in the lower extremity, which is worse with exercise and improved with rest, but does correspond to ischemic type pain in terms of description. And then often paraneoplastic pain, which is hard to describe, but should be expected or at least suspected if pain is relentless. Nothing makes it better. It's there all the time. And in particular, if the patient happens to have an underlying neoplasm. So with regard to the evaluation, if we're suspecting articular pain, the history is very helpful. So if a patient moves a specific joint and that leads to pain, that's highly suggestive that the joint is the pain driver. That's fairly elemental, but you'd be surprised at how many people overlook that obvious relationship. If there has been redness or warmth of an involved joint, that raises the suspicion of a joint-based problem. Also, if there are other joints involved, and then there's certain patterns of pain that raise the possibility that the pain driver is in fact articular. I want to insert a pearl at this point, and if all of my words pass by you, around you, over your head, through your head, or never make it there, you should always remember that anybody who presents with acute mono, meaning one joint, or oligo, meaning a few joint pain, particularly associated with redness, warmth, or swelling, you should rule out a septic process as the first and most concerning possible cause and then you can continue your evaluation. And that might be something as simple as doing an exam, talking to the patient, sometimes aspirating fluid, sending it for a culture. And then we'll talk about other things you might see on fluid exam that would essentially rule out septic arthritis. But in the face, for example, of someone who has a pre-existing condition, which would be highly associated with joint infections, such as our patient who presented today, I would be suspicious of a intra-articular infection. Now, for the particular patient, my interest is raised, but I would rule it out based on the history because he did not have mono or oligoarticular joint pain. And the flip side of the acute mono or oligoarticular joint pain as reflecting possible infection is the fact that the more joints that are involved. So in his case, if he's got MP and PIP joints, he's got 10 in one row of joints. So he's got 20 joints that he's complaining of in his hands. The likelihood of infection is conversely associated with the number of joints involved. And a thorough history, as I've said already, will frequently give very important clues to the diagnosis. So, is the problem regional, generalized, symmetric, or asymmetric, peripheral or central? Now, I'm not going to read all these because you can read them when you get the copy of the slides. But basically, I want to call to your attention that you should consider underlying medical disorders that predispose to rheumatologic problems, such as hypertension predisposing to gout. You need to assess function, including loss of motion and disability, family history, and then review the symptoms in terms of how they present, and also consider the possibility of symptoms that suggest inflammation or damage to the musculoskeletal structures. Now, the type of onset is pretty important. So if somebody shows up in your office on Wednesday and says that they, on Tuesday night, developed a hyperacute, immediate joint pain after they were kicked in the knee, you have to be very suspicious of a major injury or internal derangement, such as an acute fracture or possible conditions leading to hemarthrosis. This is the kind of thing you see in patients with sickle cell disease or hemophilia. Overnight, immediate, terrible pain associated with swelling, and it's hyperacute, and it's particularly associated with trauma. Now, we rheumatologists and you as primary caregivers will be more likely to see patients who have acute joint pain, such as hours to days. And that's typical, much more typical of an inflammatory arthritis, such as due to crystals or infection or other inflammatory conditions. If there's some delay after trauma, and that includes even the trauma of surgery, sometimes that suggests a crystal-induced disease as well. Most of the long-standing inflammatory conditions play out over days, weeks, or months. Now, there are some specific types of onset. Migratory arthritis has been associated with gonococcal disease or rheumatic fever. And as I've said, it's insidious, non-specific, seen in many inflammatory and non-inflammatory conditions. So that's not so helpful. What about the pattern of pain? And by the way, it doesn't take long to take this history. You can do it including all of the elements I'm discussing in probably 5 to 10 minutes. So you ask the patient, is the pain present at rest? And if the patient says yes, then that's suggestive and compatible with a true inflammatory process. But if it's present only with activity, it's much more likely to be mechanical, such as a torn cartilage or even osteoarthritis. And in some situations, a patient comes in with really horrible joint deformities, but has no pain. And that's consistent with what's called a Charcot joint, in which there's a severe neuropathic component, or possibly even a juvenile rheumatoid arthritis. Now, let's talk a bit about precipitating factors. So, trauma, as I mentioned, can cause hemarthrosis. It can also cause fracture, even internal or bony fracture, and it can cause internal derangement. Repetitive trauma, uh, micro trauma, is associated with osteoarthritis, and basketball is one of the conditions in which repetitive weight-bearing trauma, associated also with likely frequent injuries, is associated with osteoarthritis. And again, in Charcot joint, where the joint is denervated, there's repetitive trauma that in an individual who didn't have denervation would be painful, but people with denervation can't feel the pain. So that's why they over and over and over again damage their joints. Trauma also can cause a penetration of the synovium into the joint space, and that's associated with foreign body synovitis or septic joint. And as I mentioned, if you have recent surgery in your history and a history and or a history of recent alcohol binges, that's associated with the possibility of gout. So these are just ways to sort of process clues to try to begin to formulate your thoughts. Medications are also related. For example, it's not surprising that patients on Coumadin, aspirin, or other anticoagulants have associated hemarthrosis. Patients on steroids, particularly high dose, can get septic joints because of immunocompromise, or probably more commonly can get osteonecrosis. Patients who take diuretics are notoriously likely to get gouty arthritis, and patients on immunosuppressives are at risk for septic joint. I'm assuming that you all are aware that uh, tick bites are associated with Lyme arthritis, and usually that does not happen immediately in concert with the tick bite, but a couple of months later. So they might fool you and come in say October or November and have been in an endemic area where deer ticks are evident during the summer months. I'm not aware of whether Central California is uh, a haven of deer ticks, but I wouldn't be surprised. Vaccinations are associated with arthritis, and rubella is one example. There's a lot of association between many viruses: parvovirus, Hep B, Hep C. Um, there, you'll see on a following slide some other viruses that might surprise you. And also, as I mentioned, local joint pathology such as a puncture wound. Now, age and gender make a difference of the types of things that you'd be thinking about. A patient who's young, sexually active, and who has arthritis um, can be considered a possible suspect to have a gonococcal arthritis. And by the way, the oldest patient I ever saw with gonococcal arthritis was 65, and she was sexually active with a man who actually had gonorrhea, and she had bilateral septic knees and grew gonococcus from each of her knees. Um, it's notorious that middle-aged male patients do have recurrent gout quite frequently, more often than others. And elderly females, more so than males, often have calcium pyrophosphate deposition disease. And that may be that the females simply live longer than males, but there may be a female predominance genetically as well. It's really worthwhile to remember that septic arthritis can occur at any age, and that is actually case in point of the 65-year-old lady that had bilateral septic gonococcal arthritis. A couple of tidbits. Premenopausal women who don't have renal failure almost never get gout. And perimenstrual females tend to have clinical gonococcemia and gonorrhea, gonococcal arthritis in the perimenstrual time of their cycle. And no one really understands that, but it's basically an association. Travel history is also important. So we've talked about Lyme disease. And Zika virus is associated with generalized arthritis at the time of the infection. Chikungunya, which has been evident in the Caribbean recently, is associated with that. These are mosquito-borne diseases. A dengue fever can be associated with polyarticular joint pain, and many other viruses are as well. So it's important to get a travel history and make sure that your patient hasn't been in an endemic area where there's been even an outbreak of these diseases. Okay, so let's talk a little bit about, you've gotten all this history and you tried to put it together into a story that makes sense. Well, how do you go about doing this? This is actually something that I want you to take away also from this talk, and that is that there are two broad categories of generalized arthritis. One is non-inflammatory, and that is typified by osteoarthritis. That's subacute or chronic, and that is by far and away the most common type of arthritis that y'all are going to see. And then less frequently is inflammatory arthritis. And inflammatory arthritis may be acute, subacute, or chronic. Rheumatoid arthritis is far less frequently diagnosed than osteoarthritis, but it is basically the hallmark disease of inflammatory arthritis. And some of the other conditions that I'll be telling you more about in future lectures, and I hope that this encourages you to come, are conditions such as reactive arthritis, psoriatic arthritis, arthritis associated with Crohn's disease, ulcerative colitis, etc. Then there's microcrystalline arthritis, which I've already alluded to, gout, calcium pyrophosphate deposition disease, which causes pseudo-osteoarthritis, pseudo-rheumatoid arthritis, and also pseudo-gout. So these are all inflammatory. And there's lupus, which produces inflammatory arthritis. And then there are concurrent illnesses such as viral infections, as I've mentioned. Now, you might say, well, Dr. Upchurch, you didn't say how to distinguish non-inflammatory from inflammatory. That's true. I haven't yet. But the one thing I want you, in addition to understanding, now I'm down to my third thing, I guess. So non-inflammatory arthritis is typically not associated with any systemic symptoms. And I'll come back to this in a bit. So patients don't feel bad. They feel fine. They've just got a number of different joints potentially, which are misshapen and dysfunctional. Most of them didn't even realize that their joints were developing this deformity. Some of them have severe pain, but it's very different than an inflammatory process, which can be either acute, subacute, or chronic, and is almost always associated with significant systemic symptoms. So one thing I've said to many patients is, well, tell me, if I took your joint pain away, how would you feel? And most patients with osteoarthritis say, I would feel great. And if I say to a patient who has what I suspect to be inflammatory arthritis, that same question, they'll pause for a minute and they'll say, I just don't feel good. I'm tired. I've lost my appetite. Some of them have lost weight. So it's a very different set of circumstances. Rheumatologists, I'd like to think, are experts in diagnosis. And I think unless you are absolutely positive that what you're dealing with is osteoarthritis, and you may be, and we'll see some examples of that going forward, I would initiate early referral to a rheumatologist to confirm the diagnosis. The reason for that recommendation is that in 2025, we now have treatment approaches to many types of actual inflammatory arthritis, particularly rheumatoid arthritis, but others as well, which, if approached early with correct aggressive treatment, can be almost, I don't want to use the word cure, but as close to cure as possible. And certainly can be a remission can be encouraged, and the outcome can be far improved over a patient who had inflammatory arthritis and didn't have the opportunity to be evaluated and seen by a rheumatologist with early diagnosis and early treatment. So just remember that we're all there, and we're working on trying to increase the number of rheumatologists so that they can help you. And we're also we have rheumatologists available for consultation if you're affiliated with the MAVEN Clinic too. So please feel free to avail yourselves of our expertise in any way that you can. Now, I mentioned systemic features, and I have to give you these points. Fever doesn't distinguish between septic arthritis and gout. So gout sometimes is associated with fever. Morning stiffness more than 30 minutes implies a true inflammatory or possibly infectious process. A rash may suggest lupus, psoriasis, gonococcal arthritis, Lyme disease, vasculitis, or other systemic processes. But if there's a rash specifically associated with joint pain, that would be a reason that I would encourage you to send a patient to a rheumatologist. Other symptoms that you might not expect to be related with arthritis include conjunctivitis, uveitis, urethritis, diarrhea. So those raise other forms of arthritis than rheumatoid arthritis, which in fact are inflammatory as well. And if there's a concurrent illness of any kind, um, the arthritis could be prodromal or it could be concurrent. So, for example, sometimes polyarthritis uh, turns out to be the first symptom of malignancy. So it's just important to ask and to make up your mind whether the patient has systemic features or not. And systemic features basically kicks it into a group who probably would best be evaluated in association with your own evaluation by a rheumatologist. Okay, so I'm going to show you some pictures really quickly. Um, this is a patient with lupus, and she had a very typical photosensitive rash. You can see the area where her bathing suit covered her back. Um, this patient, though, has a more obtuse rash, which is a bullous rash, and she actually has lupus as well, because lupus can present in so many different ways in the skin. This is called bullous lupus. Psoriasis, you may or may not have seen, but this papulosquamous scaly rash, particularly over the extensor surfaces of joints, is about 15% of the time associated with an inflammatory form of arthritis called psoriatic arthritis, which has its own specific features. And I'll be talking about this particular disease in a couple of months. Here's a pustule and a little vesicle of typical of gonococcal arthritis. And there's a bulla. If you take that, lance it, and culture it, and if you're lucky, you might get a gonococcal organism, or you might see them. And there's another one as well. Very unusual these days, but we still see them. Now, this is all of these patients have lower extremity rashes. Turns out this patient has what we call palpable purpura. So if you were examining this patient, you would be able to feel these little nodules, and they become confluent in the lower extremities. You may not be able to feel these, but they nonetheless reflect palpable purpura. And then here they've become confluent, and the skin overlying the rash has basically become disrupted. This Let me see if I can go back down. This patient had occlusion of the small vessels providing vasculature to the distal digits, and he also had a form of vasculitis related to an inflammatory process that was associated with joint pain. So all of these patients had joint pain associated with these rashes. And this is called leukocytoclastic vasculitis. The particular illness that these people had was cryoglobulinemia, and cryoglobulinemia is commonly associated with hepatitis C. Um, so that's something, if you see a rash like this associated with arthritis, you need to be thinking about this. Again, I would encourage, if you see a skin rash like this, call someone and try to initiate early referral to a rheumatologist, preferably, but also a dermatologist as well. Now, this is a totally different picture. Here we see a two hands, right hand, left hand, of an elderly woman. And we don't see any changes whatsoever in the joint of the wrist, either wrist, or the MP joints. These joints look perfectly normal. Um, in contrast, we see what appears to be rock hard swelling of several MP joints, PIP joints of both hands. So the middle knuckle, the PIP joint, is very hard and swollen and marked limitation of motion. Likewise, you see marked involvement of the DIP joints. This is a prototypic picture of osteoarthritis, sparing of the MP joints, involvement of the PIPs and DIPs. So if you see this picture, there may be superimposed additional arthritic complaints that are, for example, you can have coexistent RA and OA. But if you see this as a pure picture, the diagnosis is osteoarthritis. Now, you can also get osteoarthritis in other joints besides the hands, although the hands are a particular subgroup of osteoarthritis, particularly involving women and often women whose mothers' hands look the same way. In contrast, this is a normal appearing left knee with a swollen right knee with a valgus deformity. And this is a typical finding of osteoarthritis of the knee. You can't be sure if this is if the patient tells you, well, this comes and goes, and sometimes it's red, and sometimes it's warm, and sometimes, it's completely normal. You'd really have to take a look at the fluid to see if it appeared to be typical of osteoarthritis. But this appearance is consistent with that diagnosis. Now, on exam, I've mentioned that osteoarthritis involves tenderness in the involved joints, swelling, usually bony, hypertrophic change, pain on motion, loss of motion. And just to recoup, so you'll hammer this home, the particular joints that are most commonly involved: knee, hip, thumb, that's the first carpal metacarpal joint, distal hand involvement, DIPs, the little teeny joints out there at the end of your fingers, PIPs, virtually never MPs or wrists. And then there's characteristic malalignment, such as I've shown you. Rheumatoid arthritis is a totally different story. Here, you get the sense that if you pressed on these joints, you would have almost a squishy sensation. If you look at the DIPs, there's not a smidgen of involvement with these. But the PIPs are involved, just like they can be in osteoarthritis. It's likely that the MPs are involved as well, although that doesn't show up quite as much here. Now, again, just to emphasize, MP joint involvement, this first row of knuckles, does not happen typically with osteoarthritis, except in very specific circumstances. And I'm not even going to mention those right now. In contrast, PIPs can be involved in both. The difference is this is clearly not bony, hard, type of hypertrophic change. This is soft, squishy, proliferative synovial change. And it really looks just like, it feels just like it looks too. So this is a patient who turns out had rheumatoid arthritis of the knee. And you can't really always tell the difference by looking at the knee. But in rheumatoid arthritis, there typically is synovial, not bony swelling. Again, you may or may not have pain on motion or loss of motion. And the particular joints, hands, PIPs, MPs, not DIPs. Wrists, not MTPs, not shoulders, sometimes shoulders, and definitely the ankles and knees can be involved as well. I think I've got an extra parentheses there. The characteristic deformity of rheumatoid arthritis occurs only very late in the disease, and there particularly would involve lateral deviation of the hands. So, rheumatoid arthritis is the prototypic inflammatory disease. Osteoarthritis is the prototypic um, non-inflammatory disease. These people feel really bad most of the time, whereas people with osteoarthritis feel pretty good, with the exception that they have joint pain. Now, there are other periarticular structures that can be problematic. This patient had redness that extended way beyond the joint margin, all the way down to here. And that really raises the suspicion of a bursal process that's likely, or at least the first diagnosis to be considered would be septic. Now, the bursa is constantly barraged by trauma. People who kneel all the time, for example, can get little nicks in the skin. People who bump their elbows can get a nick in the olecranon bursa. And that can lead to proliferation of organisms and to rapid onset of redness, warmth, and swelling. And the management of bursitis certainly involves excluding septic arthritis, and initiation of antibiotics is indicated most of the time until you have results of the cultures back. But this can be very painful and very acute, and you should always suspect it if you see it looking like this. And here's a patient who had olecranon bursitis, and he had his olecranon aspirated, and likewise didn't have nearly as much in the way of soft tissue swelling extending beyond the bursa. This could go either way. This could be gout, it could be or septic. And even one as angry looking as this one could be gout as well. So it's just important to try to aspirate some fluid, or get an orthopedic consult to get some fluid, or make sure that you've assessed the prospect of septic process. So what about diagnostic testing? How can that help you? Well, we generally get a CBC. The white count can be somewhat elevated in gout. It's usually significantly elevated in septic arthritis. Chem 12 can help you look at other systemic processes. We often will check serologies, not always, but a SED rate and a CRP are helpful in terms of looking for the presence of inflammation. We also may check Hep C serologies. Generally, when you check any test known to man, unless there's a secondary condition, the blood studies in OA are normal. And in RA, the SED rate and CRP are typically elevated. If you suspect RA, we encourage you to check a rheumatoid factor and also another test known as an anticyclic citrullinated peptide. Next month, we're going to have a talk that one of our esteemed other rheumatologists is going to present on diagnostic testing and serologic testing in rheumatologic disease. Just be aware that rheumatoid factor is the least specific of these two, and anti-CCP is much more specific. If you have both, it's the most specific. And also be aware that 10% of patients with rheumatoid arthritis are seronegative. And finally, be aware that there's a high incidence of low titer positive rheumatoid factor with age. Moving to anti-nuclear antibody, unless a patient has an extensive set of symptoms, which I haven't discussed today, to suggest a disease like lupus, I would probably avoid an ANA because it's nonspecific, and it's especially at low titers nonspecific. And unless it accompanies a highly suggestive history, it's usually not on the basis of lupus. And there are many other diseases that can be. Pearl, an ANA never establishes a diagnosis with certainty, never. The patient has to be evaluated. And they have to have symptoms that suggest it. Now, the same thing can be said about uric acid. Interestingly, I think a myth is that if you have a very high uric acid, you've got gout. It's true that when you do have gout and you have an aspirate from the joint, you can see uric acid crystals. It's also true that the higher your uric acid is, the more likely your chance of getting gout is. But it's finally true that you can have an elevated uric acid without having gout. And conversely, you can have gout without having abnormal uric acids. So gout is a clinical diagnosis. It's confirmed with certainty by seeing the crystals yourself. If you can't get any aspirate from the joint, or there's no one around to aspirate the joint, and you've ruled out sepsis as best you can, then you'd have to use your clinical judgment. It's true that gout is much more common in people who are hypertensive, who are alcoholics, and associated with various changes in hydration status itself, et cetera. But uric acid is non-specific but suggestive. One other thing is, if you think there might be an issue of infection, check blood cultures. And finally, if you're really considering something like Lyme disease, I think it's important to refer, because the diagnosis of viral-related illness, particularly Lyme disease, which is spirochetal related, is hard to make and is a challenge. And rheumatologists would be best to help you in that one. Just quickly running through synovial effusions. They're clear, colorless, and viscous in normal joints. Non-inflammatory, such as osteo, very few polys. Inflammatory, there can be lots of polys, but the glucose is usually normal, sometimes low. In septic arthritis, it looks like pus. But inflammatory arthritis that's vigorous can also look like pus. So you got to put the big picture together if you're using these tests, and the clinical picture is what helps you establish the diagnosis. I'm just going to show you a couple of x-rays. This is a normal knee x-ray. You can see there's nice joint space all the way throughout the joint. And these are clearly deranged. This is marked loss of joint space, and it's not throughout the entire joint. So this is highly typical of osteoarthritis. Usually the joint spaces are not involved on both sides in osteoarthritis. Now, in rheumatoid arthritis, you have symmetric narrowing, and you can see that here. The entire joint space is involved. And then here is calcium pyrophosphate deposition disease from calcium pyrophosphate crystals. And you can see that this area should be completely clear. But since there are depositions of fluid that have, of crystals that have calcium in them, the calcium shows up on the x-ray. Okay, so I've got about 10 minutes left. I do have another section in the talk. I'll run quickly through it, and then I'll stop with regard to allowing time for infections. These are crystals, and we'll have a talk on gout, so I'll come back. But let me just end by saying I'll come back to gout when we have that talk. But with regard to the patient, doc, do I have arthritis? So this patient has too much history of bilateral hand pain. And when I examine him, he has a rash. And I've told you that that suggests a systemic disease, right? He has pain in the PIPs and MPs, and he has soft tissue swelling, but he has no deformity, and he has no involvement of the DIPs. So that, plus his age, plus his sex, suggests that he doesn't have osteoarthritis. And his rash suggests that he does have a systemic disease. So do his constitutional complaints, his morning stiffness, his fatigue. It would be not usual for a male in this age group to develop rheumatoid arthritis. So I'm going to say that rheumatoid arthritis is probably not the diagnosis. Does anybody, well, I'll keep going, but I suspect you've already figured. I didn't tell you that he didn't have any complaints relative to lupus, but he had no photosensitivity, no alopecia, no nasal or oral ulcers, and nothing really to suggest a diagnosis of lupus. So let's take that off the plate. Hep B and Hep C, either one could be possible because of his IV drug abuse, but he does have this lower extremity purpuric rash, which I've told you is associated with cryoglobulinemia and arthritis. So the answer here is hepatitis C. And hopefully most of you got it. And hopefully if you didn't get it at the beginning, if you went back and worked through the process, you would get it at the end of this talk. So in summary, yes, there are many different forms of arthritis. Yes, rheumatologists are extremely likely to be able to help you sort out which a patient may have. But yes, I think you can handle and diagnose and be confident mostly in patients with osteoarthritis. And if they don't really proceed quite like you think, or if they develop new joint complaints or the findings change, you can always refer them. My final caveat is to be sure and advocate for your patient yourself if they need an appointment with a rheumatologist, and be sure also to consider MAVEN as a source, at least of consultation remotely in consultation with you as a primary provider. Okay, so why don't we stop? And we got 7 minutes till the hour's up. And I think I saw one question in the chat. That's three questions in the chat, but let's go to Jill and you can mediate the
Great.
question.
Dr. Upchurch, thank you so much for your presentation. I'll have you stop the share so we can see
Okay.
your face a little bit more
Oh,
clearly. And
how nice my face is. Okay, let me just see if I can. Okay.
I can tell that it's dark where you are. I guess it's actually you're a little bit blurred, but
Oh,
I'm not exactly
yeah, I don't
sure.
know why.
Okay. You look somewhat ghost-like, but we can still hear your voice. Um,
oh, I know. I have to turn on the light. That's why. Second.
okay, great.
Here. It is pitch black dark. It's still getting dark around. Gets dark about 10 after 4. Is that better?
Great. Wonderful. Yes, we can see you. Let's first start off with this question in the chat. Voltaren 1% gel says it is not intended for back, pelvis, or shoulder, but do you think it is okay to use for them anyways? Do you know if there is a risk for doing so?
Okay, so for those of you who don't know, Voltaren is diclofenac, and diclofenac is a non-steroidal anti-inflammatory drug. 2% diclofenac applied topically does produce a measurable anti-cyclooxygenase effect, which is how these drugs work. So in someone who has a significant history of, let's say, renal disease or liver disease, I probably would avoid it because diclofenac is associated with liver dysfunction uncommonly, but can be associated with worsening renal insufficiency. As far as the back, the pelvis, and what was the other structure? Hmm?
The shoulder.
Shoulder. Uh, I'm not aware that it's specifically better in some joints than others, to be honest. I think in general, if somebody has a contraindication written on a jar or a bottle, there was a problem somewhere along the line. So I'm not going to jump ship and say, oh, no, you can just not observe the contraindications. But I'm personally not aware of there being a problem with these. It also should be used in small measure. So.
Great, thank you. Barbara, I'm going to go ahead and allow you to talk. And so if you want to pose any question or comment to Dr. Upchurch, you can feel free to unmute yourself. And I'll give you a minute to do so.
I believe I am unmuted.
You are
Yes,
unmuted.
you
Great.
are.
Hi.
Yes, my question was, hereditary hemochromatosis is associated with osteoarthritis
Yes.
and made more aggressive by that. What are the chances for it improving if you can do sufficient phlebotomy and get the ferritin where the hepatologist wants it less than 100?
That's a great question. And first of all, the important thing about that for providers is to think about that as a possible diagnosis. And we are going to have some dedicated talks coming up. I'm doing one on osteoarthritis, I think, in the next few months. And so we'll be looking at osteoarthritis and the things that are associated with it. Um, and for those of you who aren't aware, hereditary hemochromatosis is familial, and there have to be two copies of the erroneous gene. And it is a disease in which there's excessive accumulation of iron in the joint, and it leads to osteoarthritis that has some characteristic features. In answer to your question, usually it takes a long time for phlebotomy to reduce the iron load to the extent that further damage won't occur. But I really am not aware that it can reverse damage, osteoarthritic damage that has already occurred, because the problem is it's the structural aspects of the cartilage are already deranged. And when you uh, normalize the iron, it's not going to make much difference in that regard. I'm not aware of any specific studies looking at that. I mean, I can certainly look around and see if I can find anything, but I think the most important thing that people want, the most important thing with regard to hereditary hemochromatosis is being aware that there is that diagnosis, because I bet there are a lot of people walking around who have it who don't know they have it. And it's important for two reasons. One, for the patient himself, but the second reason is for the family. And you need to do family studies and encourage the patient to have their family tested so they can have interventions early enough to prevent the kinds of problems that they have. So long answer. Most important part about treating hemochromatosis is diagnosing it early and considering it as a possible diagnosis. In that regard, come back to my next lecture in a few months, and we'll talk more in more detail about that. And between now and then, Barbara, I will look up whether there are any studies on the history of treated hemochromatosis with regard to improvement in joint structure. But my preliminary answer is no, I don't think there would be, but it's certainly important to treat it.
Great.
Thank you very much.
Thank you so much. Let's see, we'll do one more. There was a patient with typical gout symptoms on the toes. I gave a few days of indomethacin and ordered uric acid labs, but she never returned for the lab. Since you say uric acid levels are not always related to gout, should I give colchicine without the lab, or should I order more labs?
Okay. Um, That's a good question. I'd be interested to know the specific nature of the joints that are involved. 90%, 90% of patients who have gout have what's called podagra, which is involvement of the first MTP joint. And it occurs in flare-like fashion. So just to say that there's problems with the toes doesn't really help. So maybe what you could do is when you see the patient, you can snap a picture. And also the other thing you can do is a tip, if you have access to x-rays, get x-rays, because sometimes you can see lucent uh, erosions that reflect crystals around the joint, and you can have a pretty good idea that what you're dealing with is gout without doing any further studies at all. With regard to Indocin, to be honest, I'm not a big fan of Indocin, and the reason is it was everyone used to use Indocin. Actually, before then, we used fetal butazone, which is the horse drug, bute. But Indocin is of the anti-inflammatory drugs the one most likely to cause side effects. And most of these people are older individuals. And unless you have 100% certainty that they don't have any issues with their kidneys or issues with, I wouldn't use it. And also, it can cause really horrible headaches and some other things like that. The fact that she did not respond, or he did not respond to Indocin doesn't mean she does or does not have gout. Um, Colchicine is a reasonable approach, but I would definitely want to um, get a feel for whether you're talking about treating acute pain or chronic pain. And I don't have a feel for that from the question. Uh, in acute pain, it's a little tricky to use colchicine. If it's really severe acute pain, you can do a 5-day taper of prednisone, and that often will help quickly and have minimal risk because you don't continue on high doses of prednisone for more than just a few days. So it's hard to know, but I would need to know, A, is it acute? B, what do the toes look like? C, what are the x-rays? And I think you're probably on the right track statistically, but can't say for sure.
Great. Dr. Upchurch, thank you so much for giving the presentation today. We really value you sharing your knowledge with all of us. A big thank you to Clinica Sierra Vista in Central Valley in California for requesting this talk. And just a reminder to MAVEN Project partner clinics who have access not only to our continuing medical education, but to our medical consults. We have 8, or actually going to be having 9 MAVEN rheumatologists that are available for any consults that you have about your patients. So remember, you can log into your account, select rheumatology, and you can see our rheumatologists who may be available to help you with your patient questions, whether it's big, small, complex, simple. So a big thank you to all of the clinicians and MAVEN Project volunteers listening in today. Thanks for all the work that you do and taking such good care of your patients. Take care, everyone.